Welcome to the Pancreatic Cancer Action Network's webinar, Diagnostic Tools for Pancreatic Cancer. My name is Sheila Abbat, and I'm the Senior Case Manager of HCP Services for the organization. At the Pancreatic Cancer Action Network, our goal is to give you hope through better resources so you can make informed decisions. Patient Central can provide free, personalized information on many topics, including pancreatic cancer specialists and treatment options. Contact Patient Central at 877-2-PanCAN or email patientcentral@pancan.org. I would also like to take this opportunity to thank our webinar sponsor, Ispen, and to thank our scientific and medical affairs industry members, AbbVie, AngioDynamics, AstraZeneca, Halozyme, Ispen, Janssen Oncology, Rafael Pharmaceuticals, TriSalus, and TYME. The webinar is scheduled for 60 minutes and includes a presentation followed by questions, time permitting. The questions that are relevant to today's topic and more general in nature will be prioritized. A recording of this presentation and the slides will be available under the Educational Events page at pancan.org. Now I would like to introduce our presenter. Dr. Park is a gastroenterologist and assistant professor of medicine and the medical director of the Benign Pancreas Program at the Stanford University Medical Center in Stanford, California. He is also a member of the Stanford Diabetes Research Center. Dr. Park, I will turn the presentation over to you.
Great. Thank you, Sheila. Good morning, everybody, and good afternoon to those of you on the East Coast or on the Central Coast, Central Time Zone. I want to thank you all for taking time out of your busy schedule to be here for this presentation. And I want to thank the organizers of PanCAN for inviting me to participate in this lovely educational event. So as Sheila mentioned, I'm a gastroenterologist at Stanford, and I spend most of my time thinking about pancreatic disorders, as well as early diagnosis and screening evaluations for pancreas cancer. And today I'm going to focus on the topic, or the title of my talk is Current Diagnostic Tools for Pancreatic Cancer. There's a slight delay. Okay, so the objectives of this talk will be to review and summarize some of the challenges that we face in developing screening and early diagnostic tests regarding pancreas cancer, and as well as then to dive in and review our current diagnostic and staging approaches for pancreatic cancer. I'm going to briefly, at a high level, just discuss some of the novel diagnostic approaches on the horizon for you to look out for, as well as give us some hope and optimism that we are moving the needle forward. So let's start with a basic, let's just step back and introduce ourselves to the pancreas. So the pancreas is a secretory gland. It's about 6 inches in length. It's located just behind your stomach. We anatomically divide it or describe it as having a head, a neck, body, and tail. Let me just see if I can, give me 1 second. I'm going to try to get my pointer here. I hope you can see that arrow there. But so we have the head, neck, body, and tail. And you can see how it's intimately tucked away. What you don't see is the stomach that would lie over it, but it's intimately tucked into the first part of the small intestine. And it's also neighboring very closely to the aorta, which is the large vessel in red, and some of its major branches, as well as one of the main draining systems of blood back to your heart, the venous system, highlighted in blue. And that's important because the extension of a potential tumor as it approximates or touches some of these major vessels has been a technical challenge in terms of treating it, because it has allowed the tumor, if it develops, to spread quickly and rapidly through the bloodstream. The pancreas has 2 major physiological functions. In a way, it's somewhat like 2 organs. 98% of the cells that comprise the pancreas is involved in what we call the exocrine function, or the digestive function of secreting out important enzymes that are necessary for proper digestion. So in a typical day, you might eat, let's say, a hamburger. Your stomach's job is to be like a mortar or a blender and to basically break it down into millimolar particles, and then it traverses into the first part of your small intestine. Hormone signals are being sent to your pancreas to basically rev up and perform its function of secreting high amounts of enzymes, which channel its way into the small intestine along with bile and meets the food and mixes with the food and allows appropriate digestion so that you can absorb the fats and the proteins and the carbohydrates that you need for everyday living. 2% of your cells in the pancreas are of islet function or endocrine function, and these are the cells that secrete out insulin and other important hormones that help regulate sugar levels. And historically, as we think about treating pancreatic disorders, it has been arbitrarily divided into two different disciplines where endocrinologists, specialists who think about hormones, have predominantly been studying and managing patients with diabetes. Meanwhile, gastroenterologists like myself think about the other part of the pancreas on the digestive function. And we'll highlight how in some ways we should be thinking of the organ holistically because the two different functions crosstalk and might give us some further clues about diagnosing pancreas cancer early. So I think for those of you who are on this webinar, you already have perhaps appreciate some of the tough facts about pancreatic cancer. One, that it's relatively uncommon, and that has implications for screening and early detection approaches. Two, when it does present, it often presents, unfortunately, in a locally advanced or metastatic disease state or stage, in part because there are few early warning signs or symptoms when the tumor is very small and potentially curable. And many of the precursor lesions or the precancerous lesions that lead up to cancer that are sitting in our bodies as we speak or as we age or due to other risk factors are often very difficult to identify and see with current imaging. So we wouldn't even be able to see currently with current imaging strategies those microscopic lesions that, while not yet cancer, have that potential to become cancer, and those are the lesions we want to try to identify in any early detection strategy. So pancreas cancer is an uncommon cancer. One's lifetime risk for an average risk person without known risk factors is about 1.5%, which is significantly less than some of the more other common cancers like lung cancer, colon cancer, prostate cancer, or breast cancer. And as a consequence, the United States Preventative Services Task Force, which is an independent body charged with reviewing the literature on screening and making public health recommendations, which have implications in terms of clinical coverage as well as government coverage of health benefits, have reviewed the literature and basically have said and reconfirmed a previous recommendation that they had made in 2013 that for average risk adults who are asymptomatic, they have no symptoms suggestive of a digestive disease or pancreas cancer, routine screening should not be offered. In fact, they got a grade D. Grade A would suggest high level of evidence that screening would confer some benefit over risk. And we see that, for example, in another GI cancer like colon cancer. And so here they go on to specify that persons with certain inherited genetic syndromes or a history of familial pancreatic cancer are at high risk of pancreatic cancer, and that this recommendation does not apply to them. And that there are other risk factors that we're starting to explore and understand, such as new onset diabetes, which I'll talk about a little later, pre-existing diabetes, older age, and some other risk factors where they say it does apply. Now, I think to clarify, I don't think that means that they've reviewed the literature and it's conclusive that these risk factors should be included. It's my interpretation is that while these are recognized risk factors, the data to distinguish and say that this is a uniquely high-risk population has yet to be defined or described to make that evidence available for the task force to make these recommendations. So let me just kind of walk through the math and maybe break it down a little bit further in terms of why building a screening test for the average risk or for every U.S. citizen, adult citizen, doesn't quite make sense. It's not that the United States Preventative Health Services Task Force is trying to be mean or trying to economize on limited resources. It's really this kind of math example. And I hope you can see my pointer. I'm not quite sure, but let's start here at the top. So the 1.5% lifetime risk translates into about 13 new cases for every 100,000 people or Americans per year. And let's suppose we develop a brand new, novel, state-of-the-art blood test or any test that could diagnose pancreas cancer with 99% sensitivity and 99% specificity. And sensitivity, for those who don't know, let me just step back, is the performance of if cancer is present, the test will identify it. So if a patient truly has, if we had a crystal ball and we can clearly identify who had the cancer, the test was so good that in 99% of the time it would actually say this patient, the positive would say that it would capture a person who had pancreas cancer. In contrast, 99% specificity is how well does the test say that if you truly don't have pancreas cancer, how often does it actually say you don't have pancreas cancer? In other words, you're healthy, you don't have the cancer. And we assume that, and let's just suppose a 99% performance level. These test performance characteristics are somewhat hypothetical. And when you look at many of the currently available diagnostic tests we have, they do not perform this well. They're in the high 90s, but not this high. So this is somewhat hypothetical, but I'm using this to make a point. So if you go to this 2 by 2 square box, and you can see in the top row the number of cancer patients and healthy patients in these columns, and on the y-axis you'll see positive tests and negative tests. So I told you, let's suppose that there's 13 new cancer cases for every 100,000 patients. So in the top left corner you have these 13 cancer cases, and the test, being 99% sensitive, we're going to round up, captures all 13, okay? So that's the sensitivity. And if you look at the healthy individuals, you have 99,987 individuals, okay? Even if you suppose 99% specificity, so 99% of 100,000 is basically 98,987, which is that lower right corner, that it correctly said, you know, a negative test is healthy. But that 1% for such a large population means that 1,000 actual healthy patients, despite how good the 99% performance level of the test, will be told that this brand new test is saying that there could be cancer. But it's wrong. These 1,000 patients will end up having sleepless nights. A lot of testing will be done. And the basic calculation is that test that captures the 13 patients and appropriately identifies the tumor early worth the cost and the suffering of the 1,000 healthy individuals who have been falsely told that they have cancer when in truth they do not? So this is the conundrum as to why, given the low prevalence of the cancer, that no matter how good the test we have, it's probably not going to be relevant for an average risk screening population. The only thing that can change, that would change this policy, is if for some reason pancreas cancer continues to increase in the population, such that the 13 cases per 100,000 increases. If it gets to a certain critical point, then a test, assuming it works that well, could then be used for average risk screening. So this is the fundamental challenge. And this has given us some further thoughts of, well, how do we go forward? So how do we go forward? So if we can't really realistically screen the general population because it's just not that common, what we then need to do, and this is the culmination of a concept that has been evolving over the last decade about trying to further stratify the population. And this came from a white paper from a group of researchers and clinicians and advocates about how to develop a strategy to develop an early screening test. So the first part was to say, let's define a higher risk population. So in other words, let's develop a system of sieves. So let's take the general population, let's use what we know about risk factors or high risk groups and identify them. So therefore, the prevalence of the cancer will be higher. Furthermore, let's try to further enrich this higher risk population, be it with a blood test or an imaging test, And then the idea is to then take that higher enriched population to then go use conventional imaging or develop novel imaging to then find that early lesion to bend the curve and try to diagnose pancreatic cancer early. And I think that's been our general focus now in terms of developing an early detection and screening approach for pancreatic cancer. So in terms of thinking about that, who is in that first sieve, then we want to look at what are the risk factors associated with pancreatic cancer. So this is a high-level summary of the epidemiological data that's been done. It's a concise table, but it probably leaves out other risk factors, but this is just a nice summary for the purposes of this discussion. There are some acquired risk factors, such as smoking, which has a relative risk of 2 to 3 times greater. So recall that if your lifetime risk was about 1.5%, smoking probably increases your risk 2 to 3 times fold. Long-standing diabetes has been identified as a risk factor. Having chronic pancreatitis, which I'll talk a little bit more about, is a risk factor. Obesity, non-O blood group from one epidemiologic study has shown that also increases your risk. But I think it's important to see that while these are clearly risk factors, the magnitude of the risk is still relatively small. So these are relatively common risk factors. Smoking is less and less so due to our public health education and awareness campaigns. But diabetes and obesity is a growing epidemic in many ways in the United States, and that does confer a higher risk. But you can see that it's a small but real risk. In contrast, when you look at some of the hereditary genetic syndromes, which are very rare, they don't affect much of the common population, but you can see if they are present, such as hereditary pancreatitis, which is a mutation in the PRES1 gene, or the presence of a P16 mutation, you can see how some of these risks are almost 50 to 10 to 20-fold. There are some mutations which are more common, like the BRCA1 and BRCA2 and the PALB2 mutations associated with breast and ovarian, and they have smaller but real risk factors as well, but not as high as PRES1 or P16. And there are other mutations that, as we continue to do more research in this area and as we begin to look more frequently, I think we'll be discovering other mutations that will come onto this list. So let's talk about some high-risk groups. Patients with pancreatic cysts are considered to be at higher risk for pancreas cancer. This is an interesting story because if we go back even 2 decades in time, the traditional teaching was that pancreatic cysts were not very common. Actually, we have to go back 3 decades, excuse me, time has traveled, where we would have said pancreatic cysts are not common, and that the traditional teaching to medical students and residents is that when you saw a cyst, it was probably a pseudocyst associated with pancreatitis. What changed our thinking about this was, in fact, a change in our clinical practice, and that was the evolution and establishment of CT and MRI as a mainline technology for cross-sectional imaging of our abdomen. And as these imaging approaches became better and with higher resolution, we were starting to use them more frequently as part of our evaluation. We started to realize that there were many people walking the streets with incidental pancreatic cysts who had no history of pancreas cancer, and that these cysts are quite common, and up to half of them are precursors to pancreas cancer. They're not cancer yet, but they have some of the beginnings of mutations that over time show that they could have the potential to transform. And here are just some examples. On the left side is an example of a mucinous cyst, which is a type of cyst that is predominantly seen in middle-aged women, predominantly seen in the distal portion of the pancreas. They tend to be unilocular cysts. And after resected, they have this cell lining that does show precancerous changes. And underneath it, they have a very unique type of cell presentation called ovarian stroma. The more common precursor lesion is the IPMN, and these are small cysts that can involve the side branch of the ductal system of the pancreas or the main duct. And these are the more common cysts, and it's estimated that up to 15% of pancreas cancers perhaps originated from some of these cystic populations. Actually, let me go back. So I will say that, you know, our thought about these cysts went from somewhat of an alarm, in the sense that we thought these cysts were an opportunity to identify pancreas cancer patients early. But the unfortunate reality is that these cysts are thought to occur in up to 2% of the average risk population. And if we assume that only up to 15% of PDAC pancreas cancer cases originate, the vast majority of patients with cysts, even though these cysts may be precancerous, most of them are indolent in that they grow slowly. And while they might become cancer sometime in the future, it often is decades in the making, such that while we do worry about these cysts, only a very small proportion of them will actually go on to become cancer in a person's lifetime where it is relevant to follow. And it is an active area of research because we're trying to better understand which of the patients who have cysts we need to be more worried about, and which of the patients who have pancreatic cysts we can reassure and say, look, you do have this, but it's probably not going to turn into cancer in your lifetime, so let's not get too worked up about it. As I mentioned, chronic pancreatitis is another risk factor, and this is just a table that shows numerous different studies that have looked at this and shown that if you have chronic pancreatitis, a condition of recurrent inflammation affecting your pancreas, which can have many different reasons, which we can't go into for this talk. And this kind of fits our paradigm of how we start to piece together how pancreas cancer forms. We think that pancreas cancer is an accumulation of time and aging where mutations can occur in normal cells, and what may accelerate some of these mutational changes in our DNA in some of these cells is inflammation. And that perhaps repetitive bouts of inflammation, as the pancreas goes through a process of inflammation and wound healing, it accelerates a lot of cell turnover, which perhaps increases the risk of mutations forming and allowing for cancer to transform from a precursor cell. So, new onset diabetes. I mentioned that it's been established in previous epidemiological studies that having diabetes itself does predispose you or increase your risk slightly to pancreas cancer. Some of my colleagues, Dr. Chari, in fact, who led this kind of astute clinical observation, that when you looked at these patients who came into our clinics with newly diagnosed pancreas cancer, many of them had diabetes. And when you look further back, many of them didn't have long-standing diabetes. And in fact, if you go back even 1 or 2 years, many of them had no diabetes, and the diabetes developed rather abruptly. Now, it's understood that in the absence of symptoms, and given that type 2 diabetes is a very common condition, that a primary care doctor who sees a patient with new diabetes reassures the patient and says, look, you have type 2 diabetes, you need to lose some weight, you need to exercise, you need to watch how much sugar you eat, and they start to manage it that way. And that's true for perhaps 99% of the population. However, what Dr. Chari and his colleagues showed was that there is an opportunity perhaps to identify early pancreas cancer if we go back in time and see if the diabetes was relatively new in onset. And in this graph, he kind of shows in the blue line that the blue line represents these 219 cases of pancreas cancer. And when you go back into their charts to even a year ago or 3 years ago, you can see the curve of their sugar levels slowly going up within the 1 to 3 years. And they estimated that 1% of subjects over the age of 50 who have new onset diabetes, meaning diabetes developing within the last 3 years, actually will be diagnosed with pancreas cancer. And that perhaps this evolution of diabetes is the body's way of giving us a signal that pancreas cancer is lurking in the pancreas despite the patient not having any symptoms. So this has been a very exciting observation and the beginnings of a study that is being rolled out by the National Cancer Institute to better understand this phenomenon. Now, while I think there is the need to make patients and primary care doctors aware of this phenomenon, it's also important to remember that still 99% of the people who are over the age of 50, their diabetes is not pancreas cancer. So we're not ready to start doing CT scans on every adult over the age of 50 who develops new onset diabetes. It's an observation that still needs further study and clarification. And that's also why the U.S. Preventative Health Service Task Force said new onset diabetes was not included in that population for screening. I think some more work needs to be done, and I'm hopeful that in the near future, hopefully in the next 5 to 10 years, we'll have some further clarity on this topic, and we'll be able to use this as a filtering mechanism to identify those who are at higher risk for early detection. So let's move on now to what is currently available. What are the current workhorses in terms of diagnosing pancreas cancer, particularly when a patient does present for medical attention for symptoms that leads to a diagnosis of pancreas cancer? So this is a table that currently highlights what are our current tools. And you can break it down by imaging-based, which is essentially is the majority of our tests, and non-imaging-based in terms of making a diagnosis. I'm going to go through each one of them and then talk about their pros and cons. And I imagine many of you, either as patients or caregivers or advocates, are familiar with many of these technologies. Some of you may even personally experience them. And we can talk a little bit about how they work and why we use them. So CT is what I consider the workhorse of current diagnosis of pancreas cancer, in part because it's a non-invasive test. It offers high resolution of the pancreas. With current software, we can do 3D construction that can give us more information about the topography of the tumor and how it grows and exists in relation to critical blood vessels, as well as allow us to look at the evidence of spread of a tumor to other parts of the organ, commonly being the liver. Here in this figure is an example of a coronal CT scan where you see a tumor growing ahead of the pancreas, and you can see this tubular structure behind it. And this is the main pancreatic duct that has become obstructed as a consequence of the tumor growing. And we assume, infer obstruction because the duct is more dilated than it normally should. And the other clue here is that the body and tail tissue, which is surrounding this ductal structure, is very thin and what we call atrophied. It's lost a lot of healthy pancreatic tissue. And this is an unfortunate routine example or common example of a CT that we might see when a patient learns of their diagnosis. Magnetic resonance imaging is an alternative and high-resolution imaging technique that has many similar diagnostic properties to a CT scan. It's comprehensive. One of its unique benefits is that it does not use radiation, and it offers an excellent view of the pancreatic duct and biliary system. And you can see that here in this MRI that shows an MRCP view, where you can see this dilated structure is the main pancreatic duct working its way to the second portion of the duodenum. And here is the biliary duct working at, coming up here, entering into the intestine. The only downside is it's a wonderful alternative to CT scan. The one downside is is that in the CT scan, a typical CT imaging process is about 10 to 15 minutes, whereas a magnetic resonance imaging scan can take 30 to 45 minutes. Positron emission tomography, or PET scans, some of you may have had this. It is a nuclear medicine scan that works based on the principle that glucose gets consumed differentially or relatively increased in cancer cells compared to normal cells. And that differential consumption is what allows us to identify activity in the form of a bright light when overlaid on a CT scan. And this may help detect metastatic disease or lesions that may have gone beyond the pancreas that may not be clear or is indeterminate by CT scan, but is suspected. Endoscopic ultrasound. This is a approach that offers a very sensitive way to visualize the pancreas. What happens here is someone like myself, a gastroenterologist who may be trained in endoscopic ultrasound, can basically place a flexible tube down a patient's mouth. It traverses through the esophagus into the stomach. And at the tip of this special scope is an ultrasound probe, which allows us to take ultrasound images. And using a controller, we can guide the probe to look at the pancreas. If you recall, I mentioned that the pancreas is situated just behind the stomach, and the scope easily makes its way to the stomach as well as the first part of the intestine. And this allows us to visualize in very close-up detail a pancreas by ultrasound. Furthermore, it also allows us to pass a biopsy needle with ultrasound guidance. We can literally see the needle going through the stomach wall or into the duodenal wall and aspirate and sample the tissue, which is necessary for making a tissue diagnosis leading to the appropriate treatment, whether it be chemotherapy, radiation therapy, or surgery. And this is becoming more important because beyond just getting tissue now, we're learning to use the tissue to get DNA mutation profiling that may help guide the appropriate chemotherapy. We may be able to use the acquired tissue and grow them in organoids and use that to determine whether a person's cancer will respond to a certain chemotherapy or whether they'll have resistance. So the ability to acquire tissue, I think, if anything, is becoming more and more important because it's helping us lead to more personalized treatment approaches. The downside of endoscopic ultrasound is that it is relatively invasive. So unlike a CT scan or an MRI, we do need to pass this endoscope, and for comfort reasons, we do need an anesthesiologist to help sedate a patient properly to make it comfortable for you. And while it is minimally invasive, there are some associated risks that include bleeding, infection, causing a tear that might require a surgery to fix, or even pancreatitis. Fortunately, these things are actually quite uncommon. We quote anywhere from 0.1 to 1% risk. But nevertheless, compared to non-invasive cross-sectional strategies, those are some of the considerations. And that lends itself to considering endoscopic ultrasound in the screening population, particularly when a patient doesn't necessarily have a cancer, but is otherwise healthy. And you want to be considerate of the test you choose because you really wouldn't want to hurt a patient who's otherwise healthy, even though the intent is for early detection. And this is just a graphic of this probe allowing us to see the pancreas and placing a needle under ultrasound guidance. This is just a cartoon of a cyst as an example to aspirate the cyst fluid, but you can get the idea of how this works. These procedures are typically 30 minutes long with a 30-minute recovery period, so they're generally straightforward outpatient procedures. You will go home the same day. Results from biopsies typically take 2 to 3 days, which will then lead to further appropriate treatment. This is just examples of some pictures. I think one of the important characteristics of endoscopic ultrasound in contrast to CT and MRI is that although it is relatively more invasive, the literature suggests that it has higher potential to identify smaller tumors. So if you're really looking for that 5-millimeter tumor, which is in part perhaps the goal if we want to really catch it early, an endoscopic ultrasound will have a higher chance of finding that lesion with confidence and allow tissue sampling than a CT scan or an MRI scan. Not that those aren't very good, but their sensitivity to detect it if it exists drops to about 80%. And so these are some critical considerations, particularly in the high-risk populations, as to whether you get an MRI or an endoscopic ultrasound. There are the trade-offs between the two. And this is an example of some tumors are suggested by CT scan, but you don't actually see it physically. So here's an example of a CT coronal section of a patient who has a pancreas cancer, but you can't actually see the tumor in the pancreas. What you see is the smoking gun sign of a stricture, this narrowing. You can see the duct in the body and the tail, and it's somewhat prominent and dilated. And then you can see this abrupt cutoff, and then you can see how the duct continues. This white line is a biliary stent that has already been placed in a patient who presented with jaundice. But here you can't actually see the tumor, but you suspect it's there because of the way the duct is behaving. And in this case, we did an endoscopic ultrasound, and in fact, there was a 3-centimeter tumor that technically the CT couldn't see, but strongly suggested. But on ultrasound, you could see this, the borders of an actual tumor. We were able to do a tissue diagnosis with a biopsy. And this just is an example of how there are different operating and diagnostic characteristics of these imaging tools. Endoscopic retrograde cholangio-pancreatography, that is a mouthful. We typically refer to this as ERCP for short. And this is another type of endoscopic procedure where we actually cannulate or place a wire or a stent in the common bile duct or in the main pancreatic duct. In the past, we used to do this for diagnostic purposes where we suspected a stricture or we suspected a tumor. Nowadays, because of the risk profile of this particular type of scope, we really limit its use for specific therapeutic indications. For example, if a patient comes in with jaundice and a CT scan shows that there is a tumor obstructing the common bile duct, then an ERCP would be appropriate not to diagnose the tumor, but to place a stent to decompress the obstructed bile duct. Similarly, if we thought that there was a stricture in the pancreas that was causing some patient's symptoms like abdominal pain, or a stone that needed to be removed, that would be a therapeutic intent. But we don't typically do this just to take a look and see the ducts because MRI and MRCP has essentially replaced ERCP as a diagnostic instrument. And so we are limiting its use to specific therapeutic purposes. There are no real blood tests currently available for screening. For diagnosis, we do consider cancer antigen 19-9 or CA19-9, which stands for it's a carbohydrate antigen that can be differentially secreted by tumors. It is by far not a perfect blood test. There are many benign explanations for why someone might get an elevated CA19-9 that I highlight here on the left. Any certain types of inflammation in the pancreas or in the bile duct and liver disease can cause elevations in CA19-9. But it is raised in pancreas cancer and in other gastric and colorectal cancers. We do not currently recommend getting a CA19-9 just to screen or if someone's having very benign, non-specific symptoms because of the map that I showed you before. While it might identify some patients, it often leads to a lot of patients who are worried sick because they have a blood test that is elevated and a tumor cannot be seen. And then the reality is that in many of these patients, it's just elevated for benign reasons. And this is an example of why we want to use this test carefully because we want this test to help and not hurt. We do use it if a patient does have a diagnosis of pancreas cancer. It can be used by our clinicians to track progression and regression to chemotherapy. And so you will see it if you have pancreas cancer that your doctors may often test for it. And as you're undergoing chemo or radiation, they may check it periodically as a surrogate or as an adjuvant marker to give them some hint as to whether the tumor is responding. Again, it's not perfect, but it's what we currently have. I will say that there are several different investigators in the country who feel that CA19-9 has more promise than currently heralded, and are trying to retool this assay to make it more sensitive and specific. So that is an example of something that might be on the horizon in terms of where we might be able to go with it. So when you think about these imaging tests that I just went over, you want to think, well, what are their purposes? Can they be used for screening? Can they be used for early diagnosis? Can they be used for diagnosis? And then can they be used for surveillance for patients who already are being treated for pancreas cancer? And so this is a general table of what is currently recommended among these available imaging-based and non-imaging-based strategies for screening and early detection. And basically, the current consensus that is if you have the appropriate individual who's deemed high enough risk for screening, not the average risk person, then MRI or EUS is probably the preferred or recommended screening modalities. Centers will alter based on their philosophy about whether they'll do MRI-based or EUS or whether they'll alternate. Centers that place an emphasis on no harm to the patient and being more non-invasive will stick to an MRI-centric approach, and centers that perhaps focus more on trying to find the smaller tumors will perhaps push a more EUS-based approach. But you want to, if you are a patient in this high-risk population, this is a discussion you would want to have with the cancer center that you choose to get your care at to find out what is their approach. For diagnosis and staging, I think CT remains the first line approach because it is fast and easy and highly sensitive, and many of our current clinicians are very comfortable with using CT and interpreting CTs. I would say that our surgeons are very comfortable with using CTs in the operating room to help understand the anatomy. I think more and more they're becoming more comfortable with MRI, but I think for some of those operational aspects, CT remains the workhorse. We don't really use PET scan upfront for diagnosis, but if we do suspect metastases, we might consider it for staging purposes. EOS will be used for tissue acquisition. ERCP, as I mentioned, is for therapeutic purposes. As I said with C19-9, we don't necessarily use it to diagnose, but when it is diagnosed, we can use it as a supportive biomarker. For surveillance, we'll often use CT scans to see whether the tumor has regressed. PET scans can be helpful when the CT is indeterminate. A common example is a patient who may undergone surgery, and then there's a lot of post-inflammation and fibrosis. And then when they do CT scan, the area where the operation occurred, the planes of the anatomy are not as clear cut, so you may want to use a PET scan to see if there's some small evidence of residual tumor. That might just be an example of how a PET might be used over a CT scan. So real briefly, I'm just going to touch upon, we have about maybe a couple more minutes left in my talk, and then we'll take questions about potential new diagnostic strategies that I think are on the horizon. And I'm not really going to talk about specifics. I'm really just going to highlight that, with the evolution of very exciting new techniques in the lab about understanding DNA profiling, our ability to look at large samples of cells and look at microRNA profiling. We have various different proteomic technologies that look for a variety of different proteins that might be increasingly secreted or expressed in cancer versus healthy patients. We're looking at metabolite differences. We have the capacity to look at metabolite differences in cancer versus non-cancer. There's been a lot of interest in another unique biological process called exosomes, as well as cytokines and circulating tumor cells. So these are all things that are happening rapidly and progressing quickly that we're using often in the preclinical animal laboratory to better understand and characterize the biology that drives pancreas cancer. But we're also taking these insights and trying to develop tests that can then be applied in the clinical setting. And so we're using and leveraging these technologies to develop new blood-based biomarkers, cyst fluid biomarkers, creative juice biomarkers, and even using the urine. And so there's a lot of excitement and a lot of interest, and if you look in the literature, you'll find a lot of different applications of potentially promising biomarkers. And so it's not for a lack of promising biomarkers, I think the real rate-limiting step in getting these available to patients is trying to get the appropriate infrastructure so we can robustly test whether these biomarkers truly work in the human clinical setting. And that is something that takes time and effort and a lot of investment in resources to make happen. Even if we, even if we develop, and I'm very optimistic, we'll have some new biomarker tests that will improve upon CA19-9 that we will start to use hopefully in the clinic in the next 5 years. We still need to be able to see where a very small tumor might exist within a pancreas. So hypothetically, if a new test says, hey, Mrs. Smith has a high test level, so we're very concerned that a tumor exists, but then if we use a conventional CT or an MRI or even an endoscopic ultrasound, we might say, gee, okay, we're worried, we can see the blood levels, but we can't find the tumor. So we need to develop new imaging approaches and innovative approaches that might allow us to see better. So there are several different approaches that are under research and investigation. Artificial intelligence and radiomic approaches, which essentially is taking the raw data from the CT scans and the MRI scans that are currently being used and trying to find ideas or signals that the human eye may not see, is under active investigation and probably has a lot of potential to be entered into clinical use sooner than other approaches. The limiting step has been making sure that having enough images for such an approach to have a computer or have an approach be validated before you unleash it into clinical practice. Another approach is to use what's called molecular imaging, and that's trying to improve upon the current PET scan. I mentioned that PET uses glucose. Well, one of the reasons why PET is somewhat limited is because in addition to cancer cells, any type of inflammatory cell will consume glucose relatively faster than a normal cell. So the glucose tracer is good, but not good enough. And so leveraging what we understand and learn about the biology of pancreas cancer, there have been various active investigations to develop new tracers that link to a protein instead of sugar that is unique to the cancer and not just to a general metabolic process. And so, for example, we have a clinical imaging trial looking at whether a novel PET tracer could identify pancreas cancer better than the current conventional PET-based approach. And we hope that we have some very potentially promising results, and we hope we can, if we continue to validate this, this could be then used in practice. I mentioned that endoscopic ultrasound has the ability to see smaller tumors, but even then, it still could use some assistance. And so there's been another approach using contrast microbubbles that are injected into the bloodstream that might help enhance a tumor if it exists. Going one step further, we've been labeling these little microbubbles with specific proteins that link to the vasculature of the cancer in hopes that it'll stick and stay longer. And in this example here, we can show that in a mouse, we can see a tumor that's less than 3 millimeters as it lights up because the bubbles are sticking to the tumor. And so we're hoping to use these observations and translate that into human studies, and we do have some imaging studies for human clinical trials now to see if we can detect these tumors earlier. So what I hope to have tried to convey to you is, and I thank you for your patience, is that pancreas cancer is an uncommon cancer, which has implications about developing early detection and screening strategies, but we're trying to define high-risk populations better. We're trying to enrich these with the development of novel biomarkers. We're trying to find them better with manipulating current imaging strategies and developing new molecular imaging strategies that might find smaller tumors. In terms of what we have currently about how we go about diagnosing pancreas cancer, we reviewed many of the current workhorse modalities, CT being one of them. MRI is a good alternative. Endoscopic ultrasound can be good for small and occult tumors and allows for tissue diagnosis, which is of increasing importance as we start to personalize medicine and try to get DNA, mutational profiles of personalized treatment. ERCP remains to have a role in decompressing the bile duct, which gets obstructed from pancreatic head tumors. And PET scans are useful in helping identify staging of disease, particularly when a CT is indeterminate, but it can be improved upon. And I hope to convey that despite some of the tough challenges and realities of treating and diagnosing pancreas cancer, there's a lot of excitement about new and innovative approaches that are on the horizon. So thank you for your time.
Thank you, Dr. Park, for a wonderful presentation. At this time, we do have time for questions. So to start off, the first question is, what type of doctor should an individual see to determine pancreatic cancer risk?
Great question. So I think it depends on the situation that you're in. So if you believe, the first question is, why do you believe you're at risk? If you think you're at risk because a family member of yours has pancreas cancer, well, the first thing that should probably take place is, and this is a relatively new guideline, is that the family member who has pancreas cancer, in addition to getting their treatment, should actually undergo genetic counseling and have their own and be tested for hereditary genetic mutations. It's a new recommendation in the NCCN guidelines, and that would then have implications because if that family member does test positive for a mutation, then immediate family members in the first degree would also want to be tested to see if they also carry that mutation, and that would have implications for screening and early detection to determine if they're in a high-risk group. That can begin with talking to your primary care doctor, who can then place a referral to a high-risk genetics clinic where you would meet with a genetics counselor who would go over the pros and cons of genetic testing, making sure you understand what you're signing up for, and then getting tested. Now, if you do have a cyst or you do have a family member with pancreas cancer, or you've been tested and you have and you harbor a mutation, then it does vary based on your local resources. You'd probably want to start with your primary care doctor and explain to them what you're looking for, and they may identify resources or identify a specific cancer team that is interested in this. And oftentimes that can be a gastroenterologist who focuses on pancreatic disease like myself, and they can talk through with you in terms of what the approach is. In some centers, it's even an oncologist who, although their training is to treat cancer, because of their interest in prevention, they may be focused on it. So I think it will vary depending on your local context. It's not strictly based on traditional discipline.
Perfect. Thank you for that comprehensive answer. The next question is, if an individual has diabetes, is there anything they should be talking to their doctor about with regards to pancreatic cancer risk?
So it depends upon the circumstances of the diabetes. If you are now hearing about this now and you look back and you've had diabetes for 5 or 10 years, well, then the chance that your diabetes is a reflection of an incipient or evolving tumor is probably not the case. You have diabetes for other reasons, but that does increase your risks somewhat small. I think what I would recommend at that point is just using this as an opportunity to incentivize that person to pay attention to trying to keep good control of their diabetes by, number 1, being careful with their food choices, number 2, making sure that they're exercising and trying to keep their weight down, number 3, making sure they're compliant with the medications that they need to be taking to keep their diabetes under good control. If the diabetes diagnosis is relatively new, at this point in time, I think what I would suggest is we do not have a clinical proven algorithm that would say just because you have new diabetes and you're over the age of 50, you should get a CT scan. The evidence is not there yet. It's just suggestive. What I would suggest you do then is to talk it over with your primary care doctor and I think implement some intervention strategies such as losing weight and eating right foods and taking your medicine, but perhaps watching it closely and taking it more seriously. Remember, 99% of new diabetics is still type 2 diabetes and not pancreatic cancer. So chances are when you do develop new onset diabetes, it's not related to the pancreatic cancer. I think the observations here just reminds us to be a little bit more aware and proactive about treating diabetes.
Perfect, thank you. The next two questions focus on endoscopic ultrasounds. So the first being, should an individual be asking their gastroenterologist to obtain additional tissue during an EUS for tumor profiling?
So in the context of pancreatic cancer, in other words, a patient who is undergoing an endoscopic ultrasound for tissue diagnosis because there is a known mass, it's a very appropriate question. Part of it is to have that discussion with your gastroenterologist to say, if hypothetically this is a tumor, are you collecting enough that can then be used later on for tissue tumor profiling? I think it's an appropriate question. What typically happens is, though, when in terms of the normal workflow is a gastroenterologist who performs endoscopic ultrasound will take the tissue, and that tissue will be taken to pathology, and that tissue is basically staying there. So if tests need to be done beyond that, it's the pathologist who will assist in getting those tests done. Now, I think there has been some changes in endoscopic ultrasound and needle technology such that there are needles that are able to acquire more and more tissue. We call these core biopsy tissue needles that are seen to be safe, but also very efficacious. So I think you will see a trend where we're actually able to get more tissue. But I think making your doctor aware that you want to make sure that adequate tissue is available for analysis afterwards is important to just note so that they'll be sure to get enough tissue. Because sometimes they just get enough tissue just to make the diagnosis, and it's an important conversation to have.
Perfect, thank you. And the last question would be, where can one or how can one find a doctor who can perform an EUS and other imaging tests?
So I think there are many different resources that you have. You can first have a discussion with your primary care doctor or your local gastroenterologist if you've established care. Endoscopic ultrasound is an advanced endoscopy technique, but more and more, in my own experience, I think it's available out in the community and various different practices. That would be perhaps one way to go about it. You may also want to identify regional or national cancer centers that are realistically close to your location and inquire about referrals there, particularly if you think you might want to get your cancer care or your digestive health care, as they often will have. They tend to have more specialized programs than what a community practice might be able to handle. So, and you can use resources like PanCAN, like the National Pancreas Foundation, like, and frankly, I think in my own experience, I think a lot of patients just use Google. Not that that's a great thing, but it's definitely a tool. And when I talk to some of my patients, that's often how they find or choose a center.
Perfect, thank you again. And with that, we would like to thank Dr. Park for his presentation. The PowerPoint slides and a recording of this webinar will be available at pancan.org under the Educational Events page. There may be a delay of several days before the information is posted, and your patience is appreciated. Once again, we would like to also thank our webinar sponsor, Ipsen, and our scientific and medical affairs industry members, AbbVie, AngioDynamics, AstraZeneca, Halozyme, Ipsen, Janssen Oncology, Rafael Pharmaceuticals, TriSalus, and TYME. A survey will pop up once you leave the session today, so please take a moment to share your feedback. If you have questions, please contact Patient Central at 877-2-PanCAN and ask to speak with an associate. This concludes the webinar. Thank you.